Hello, everyone. Good evening, everyone, to one and all. On behalf of Future Varsity Education Group, Lifeness Science Institute, I extend a very warm welcome to all the distinguished guests, speakers, and participants joining us today for the webinar on pre-hypertension, medical and dietary perspectives organized to commemorate the World Hypertension Day. Future Varsity Education Group is a pioneer in education for more than 2.5 decades, with its presence not only in Mumbai but also in Delhi, Ahmedabad, Jaipur, Dubai, USA, and Singapore. Future Varsity Education Group has been instrumental in successfully introducing new age curricula for University of Mumbai and other renowned universities approved bachelor's and master's degree and diploma programs. These programs provide a global exposure and a competitive edge to the students with their innovative programs, integrated learning, state of the art facilities, expert faculty, holistic development, internship opportunities, and placement assistance. Lifeness Science Institute, one of the verticals of Future Varsity Education Group, is a specialized educator in the field of integrative nutrition and dietetics. LSI offers courses at undergraduate and postgraduate degree levels in collaboration with various reputed autonomous colleges like MKES Nagindas Khandwala College, Empowered Autonomous, Malad, BK Birla College, Empowered Autonomous, Kalyan, the IPA MSB's Bombay College of Pharmacy, Autonomous, Kalina, and RAV's Lakshmi Chand Golwala College, Autonomous, Ghatkopar, affiliated to the University of Mumbai. Through LSI's strong collaboration with food industries, medical institutions, fitness centers, and community welfare organizations, it empowers its students with the necessary exposure and practical training leading to their enhanced employability. LSI has been ranked number 1 in India for excellence in academic achievement by Education World Grand Jury Higher Education Ranking 25-26 and ranked number 1 as exceptional community expert in the academic year 24-25. Today's webinar is jointly organized by the Future Varsity Education Group Lifeness Science Institute, Nutrition Society of India Mumbai Chapter, and the Indian Association of Parenteral and Enteral Nutrition Hypertension Core Group. On this important day, let us come together to raise awareness and promote practical approaches in managing hypertension, a silent threat that affects millions globally. Let us unite our knowledge, experience, and enthusiasm to take a meaningful impact. We request everyone to please switch on your cameras. With immense pleasure, I would now like to introduce Dr. Neha Sanwalka, the Secretary of NSI Mumbai Chapter. She is an esteemed nutritionist and researcher with extensive experience in the fields of clinical nutrition and biostatistics. Dr. Sanwalka is the director of NutriCanvas and holds a PhD in health sciences. Her contributions to nutritional research, particularly in the areas of pediatric nutrition, public health, and body composition analysis, have significantly enriched our scientific understanding and practical approaches. We are honored to have her with us today. I would now request Dr. Neha to say a few words about Nutrition Society of India, Mumbai Chapter. Over to you, Dr. Neha.
Thank you so much, Rashi. Can I share my slide, please?
Yes, ma'am.
On the outset, I'd like to thank LSI, Lifeness Science Institute, Gopal Sir, Subhadra ma'am, and the entire LSI team for collaborating with NSI on this very important webinar. So just to introduce LSI to all of you all, NSI was established in 1967 in association with and is an association of nutrition professionals, programmers, and policymakers We are Indian representative of at the International Union Nutritional Sciences through our hearing body, Indian National Science Academy and Federation of Asian Societies of Nutrition. NSI, as a society, we disseminate the results of latest research, analyze current status, and recommend appropriate strategies to promote nutrition to society at large. NSI does community outreach programs. We do a lot of scientific programs and also publish a lot of material. To know more about NSI Mumbai chapter activities, you could go to nsimumbai.org. And to take the membership of NSI, you could log on to nutritionsocietyofIndia.com. And you could know more about NSI Mumbai chapter by following us on our various social media handles. We are present on Instagram, YouTube, as well as Facebook. Today's webinar is extremely important because a lot of patients suffer from pre-hypertension in India, but they go undiagnosed. And as nutritionists, it's our duty to help these patients curb and manage their pre-hypertension and prevent it from converting to hypertension. So we are looking forward to listening to both our esteemed speakers. Thank you so much. Over to you, Aditi.
Thank you so much, ma'am, for your insightful words. Moving forward, I would now like to introduce Professor Bijoya Bhattacharjee, a prominent member of the IAPEN Hypertension Core Group. Professor Bhattacharjee is an assistant professor and HOD of Dietetics and Applied Nutrition, Amity University, Kolkata, and is also founder and clinical dietitian at Clinical Nutrition and Wellness Solutions, a joint venture of RB Wellness and Nutrition Academy and RB Diet Clinic. I now invite Professor Bijoya ma'am, the official representative of the IAPEN Hypertension Core Group, to share a few words.
Thank you, Aditi, for the kind introduction. Hope I am audible. Well, a very good afternoon to all the participants, and I extend my heartfelt thanks to the LSI for collaborating with IAPEN India Hypertension Core Group. Thank you, Gopal sir. Thank you, Shubhadra ma'am, for this opportunity. So, well, IAPEN India Hypertension Core Group is actually a one of its kind initiative, first ever in India, which is actually addressing the rising incidences of the hypertension. And this rising incidences of hypertension in the developing countries is actually an indication that it's a high time that we should be paying more focus in changing the lifestyle and an epidemiological transition with the shift from communicable to non-communicable diseases, which is happening. So there also, which Dr. Badani will already be highlighting, and even Dr. Eileen as well. So hypertension often goes undiagnosed, and it is frequently diagnosed accidentally or when there are certain complications. So raised blood pressure, which is a long-standing condition, definitely needs certain lifestyle changes for both prevention and as well as management. And hypertension is the number one risk factor for the global death. Around 10.8 million people die every year due to raised blood pressure. But yeah, it cannot be treated unless it is detected. So detection is very, very important thing. And according to the global epidemiological data, less than half of people who have high blood pressure actually know that they have it. So that is more dangerous because people are hypertensive, but they're not even aware of it, even though detection is very simple. So here we are from the IAPEN India Hypertension Core Group, we are actually focusing on towards the improvement of the awareness by helping people to get their blood pressure checked at least every May, completely free all across the world with a squeeze arm squeeze, and with that we can just save millions of lives. So for all the participants, we would request to please be a part of this endeavor. The Hypertension and the Nutrition Core Group of IAPEN India, it basically aims at training the healthcare professionals and the community towards preventing, diagnosing, and managing hypertension and following healthy lifestyles. So it is imperative that the healthcare professionals be trained to encourage task and sharing and like the task shifting in order to manage the rising burden of the hypertension, which needs to be addressed. So the Hypertension Core Group has been successfully conducting 3 month certificate course on lifestyle management in hypertension as well. And we are also dedicated to evidence-based research practice, and hence we also pursue continued research in the field of clinical nutrition, especially in the cardiovascular diseases and other metabolic syndromes. So this is what we are actually doing in the Hypertension Core Group. And if anybody is interested to collaborate with us, you can actually follow our social media handles in the Facebook, and you can also go to our IAPEN India websites. Apart from the hypertension core group, there are a lot many other core groups as well. So whatever suits your interest, you can definitely join, because at IAPEN we are truly committed towards awareness and for the betterment of the dietetic fraternity, because nutrition, it starts from conception and it ends at death. So we focus from that perspective. So now, without much ado, we will be moving ahead to our next event. So, over to you, Aditi. Well, Dr. Rajesh Badani, a very well-known face in the field of the cardiology, is basically MD, DNB, FCPS, and DNB Cardio, FESC, FSCI Fellowship in EP. He is the Associate Director in the Department of the Cardiology at Aditya Birla Memorial Hospital, and has been serving the nation for more than 18 plus years. He is specialist in complex ablation or the device implantations, complex coronary angioplasty, and imaging guided PCI. DNB cardiology teacher since 10 years, and he is also the recipient of a prestigious DP Basu Award for Best Original Research across India at CSI Chennai 2008. He has been the past president of CSI Pune, and he has got special focus on preventive cardiology, and he is also holding 10 international and 15 national publications, and has been delivering multiple talks at national and international platforms. So, sir, it is our pleasure to have you here. And so now the platform is all yours, and we are eagerly waiting for your lecture. Thank you.
Professor Vijay, thank you, Nutrition Society of India, for having invited me. So I believe it's a mix of clinicians as well as the dietetic experts who are going to be a part of this program. So what I am going to be talking to you about is about pre-hypertension when we are talking. So how to approach? Before I start or take it over, we need to understand that hypertension is a silent killer. It is the number one non-communicable disease which causes death as well as disability in the population. As of today, the prevalence of hypertension is 33% in the urban and 29% in the rural population. So almost one third of every individual, wherever you see, every 1 in 3 people are going to be hypertensives. And the interesting aspect is that the people who have hypertension between 18 to 45 years of age, 65% of the people of hypertension are in this bracket. And between 55 years to 75 years is the other 35% which is there. So today the difference in hypertension that we are seeing is young hypertensives. Hypertension association with coronary artery disease is very strong. And people with just plain hypertension, because of the vascular involvement, people can have coronary artery disease, acute MI, sudden cardiac death, ventricular arrhythmias, and all that. Coming to the topic of pre-hypertension, first of all, we need to understand that pre-hypertension, definitely this term was in vogue till the last ESC publication, which was done in 2024, where we need to understand that optimal blood pressure is anything below or equal to 120/80. Pre-hypertension is 120 to 139 systolic or 80 to 89 diastolic, and established hypertension is more than or equal to 140/90. So I think as Professor Vijay was talking about, our main challenge is of the diagnosis of this particular hypertension, and from medical experts, we have a major challenge of convincing the patient that are you a patient who is elevated BP? And once you have this elevated BP or you have a pre-hypertension, we have to understand certain risk factors. If somebody has diabetes, somebody has had a past stroke, your guidelines tell you very clearly that the blood pressure should be given or tried to be maintained below 130, even into the tune of 120/70 in stroke patients, 125/75 in diabetic patients. So basically, pre-hypertension is not only pre-hyper because it has the term hypertension involved into it. So all the problems that a hypertensive patient can face, even a pre-hypertension is at a much higher risk to have that problem in future. So for today, what we will be only focusing is the importance of out-of-office blood pressure measurement. Is it really useful? Should it be done regularly? and how is it really beneficial over and above our office blood pressure. So the introduction, what we want to know is OBPM obsolete? Role of newer methods of blood pressure measurement, and ABPM and HBPM shall replace OBPM in the near future. Now, this is very interesting. We should know that River Oki did the first BP monitoring in humans, and the BP variability, when we talk of, this was in 1896. They said it is enough to speak to the patient, invite him to read or look at him suddenly, or perhaps it will take a sudden noise, a carriage going past in the street, a shout of a loud but distant noise to make the BP rise, and not necessarily to the same extent in all cases. Although it is not the only factor, simple application of the instrument can cause a temporary rise in BP. It is therefore necessary to take not just one reading, but several in succession. So that is one important take-home message for all of you today, is that one single BP reading, which is abnormal, doesn't or should not be labeled as antihypertensive because of the following reasons. And poor control is largely related to the systolic blood pressure. 66% of the majority of the patients have BP more than 140, and 27% of the people may have a BP which is above 90 diastolic. So thus every millimeter of BP counts, and hence accuracy in BP measurement is a prerequisite to the management of hypertension. So we need to understand very well that even if my patient is a elevated BP, 135 by 85 or 130 by 87, that one single value is not going to define somebody as hypertensive, but I probably need to take a varied variety of values. What are the factors that affect blood pressure measurement? I think these are very important to note, whether it is office, ambulatory, work or home, daytime, nocturnal, evening, morning surge, and postprandial. Observer, doctor, nurse, technician, self or automated. Device, mercury, which is presently already been outdated. We are not supposed to use mercury manometers, though in India it is still being used. But according to the guidelines, mercury manometers are not to be used. Aneroid, hybrid, oscillometric. Posture, lying down, sitting, standing, or after exercise. Reading, should you take the first reading? Should you take 3? Average of 3, remove the first and take second, third, and average of that. First day, first visit, several measurements. How should you do it? Big challenge. Calculation, should you take the average? Should you take the variability? Should you take the reactivity? Should you take the maximum? And now we have a new concept of time in target range, TTR. The pressures above X value is out of range. Pressures below X value is out of range. Now we need to understand there are multiple doctor-related pitfalls. Missing the auscultatory gap, fast cuff deflation, monitor not at eye level, terminal digit preference, uncalibrated equipment, air leak, and single reading. Normal Kaplan, who is the father of hypertension, said that measurement of blood pressure is the clinical procedure of the greatest importance, but performed in the sloppiest manner. That means we are not at all serious as to how and which way should we measure our pressure. When we talk of BP measurements, it's very clear it is office or clinic. And second is home BP, that we'll call it as, label it as HBPM. And ambulatory blood pressure monitoring, which is a device which will measure your blood pressure every 30 minutes in daytime and 1 hour in the nighttime, and would give you a 24-hour average, daytime average, and nighttime average value, if at all you want to diagnose hypertension scientifically. Recommendation of out of office. Now you will tell us, what is the reliability? Why should I do that? I'm sure my doctor is going to be more accurate. My assistant is going to be more accurate. So the answer is, the guidelines tell you very clearly that out of office blood pressure or self monitoring of BP is a class 1A recommendation for titration, diagnosis of hypertension, and titration of medication. This is very, very important. Now let's talk about home blood pressure monitoring, which I think all of us have BP machines, but we have a lot of questions about it. Is it reliable? Is this machine accurate? Should I rely on what has been given? Can I change the medication with this? Should I show it to a doctor? What should I do? So is it feasible? The answer is yes, of course, it's very, very feasible. What if the training of the patient is needed? Is only 10 minutes of training is sufficient? Which machine? Technically, Omron HEM 7130 or circa 12080 of the Microlife has been approved, but there are many other approved machines which you can be used. How many readings in a day? This is very important that the Hope Japanese Society of Hypertension has now, for the diagnosis of hypertension, come up with the 227 concept. 2 readings 2 times in a day for 7 days. If you do that and if your average is above 135/85, you are a hypertensive. But imagine you are 130, 120 to 134 and 80 to 84. Definitely, I would like to monitor you very closely and see that if you really cross this value, maybe starting therapy little earlier in a high-risk patient would also be very appropriate. Now, when we talk of, there are 4 varieties of hypertension which you cannot pick up by your plain office blood pressure. Number 1 is masked hypertension, white coat hypertension, sustained hypertension, and sustained normotensive. On the right axis is the office blood pressure. X-axis is home or ambulatory BP. So now understand, untreated subjects, if somebody has normal office BP and normal home or ambulatory BP, he is a sustained normotensive. Imagine somebody has a high office BP, but normal home BP is a white coat. So he doesn't need treatment, but needs close follow-up. Somebody who has normal office BP, but a very high home or ambulatory BP, it's a masked hypertension, very dangerous. And the last is high office and high home BP is a sustained hypertensive. This is very important that we need to understand. And this is the one of the very interesting data. You'll ask me, what is the study? We have a very large trial called the Indian Heart Study, which was probably published in 2018. Self blood pressure monitoring as compared to office BP measurement in a large Indian population. It was 18,900 patients, 42 plus minus years, 1,237 primary care physicians. On the first basis, there was 30% of individuals were normotensive, 27 were hypertensive, 23 were white coat, and 18.2 were masked. So let me tell you that if you do not do home blood pressure monitoring, you will miss a large chunk of people, 20% who deserve therapy because of masked, and 15 to 20% who do not deserve therapy because they are white coat hypertensions. And there is a poor agreement between office BP of visit 1. Likewise, the agreement between office BP at both visits and self BP monitoring was very poor. Self blood pressure monitoring is considered to have a better correlation with patient prognosis and should be the preferred method for diagnosing hypertension. Now, current status of home BP is recommended for diagnosis of hypertension. It measures important predictors of target organ damage, provides better prognostic information, recommended to monitor antihypertensive therapy, telemonitoring to control BP, wearable devices for cuffless or non-invasive beat by beat monitoring, generate data to inform AI strategies, and devices with ability to monitor temperature and environmental conditions or detect arrhythmias. Nocturnal hypertension monitoring is very important, and early morning BP surge is one of the major things that we need to identify with the home blood pressure monitoring. Look at the recommendations, all the guidelines of American College of Cardiology, European Society of Hypertension, ISH, JSH, China, Taiwan, South Korea, and Hope Asia Network. All of them, let me tell you, are used for diagnosis of hypertension and titration of the antihypertensive therapy too. Another very important message should be that when should you take the morning blood pressure and when should you take the evening blood pressure. There is a very clear recommendation. The morning BP should be taken within 1 hour of waking, after urination, before breakfast and drug intake, and before you go for a walk. It should be done in a comfortable chair where your back is leaning, legs are not crossed, body is straight. My BP cuff and the machine should be at the level of the heart. 2 readings with 1 minute interval twice daily for at least 3 days, but preferably 7 days. And evening, you have an option either pre-dinner or before going to bed. This is something which is very important. Now, is there a relevance? That's what I want to know. Association between home blood pressure and stroke risk. Look at the red bar. We were talking about pre-hypertensive, below 135, almost. Why we don't need to treat people with pre-hypertension presently is because the stroke risk hazard ratio is very similar. The moment your pressure rises to 135 plus, morning BP is high and evening BP is little low. So 2.5 is the hazard ratio for stroke. So the higher the value of the systolic blood pressure in the morning, higher is the hazard risk for stroke. And that is the reason home blood pressure monitoring is one of the key essentials that we need to be followed. Now, coming to target is that please target your morning pressures. If your morning pressures are above 135/85, please bring it down to below 125/75. And once that is being achieved, then you target the masked uncontrolled hypertension by either circulating volume, vascular disease, obstructive sleep apnea, and insomnia. All of this put together, then you use drugs, and if you see the nocturnal BP below 120, that is called perfect cardiovascular risk reduction. So in a nutshell, please, we need to understand that home blood pressure monitoring is one of the key aspects if you want to pick up hypertension early, you want to pick up pre-hypertension early, and you want to treat them little earlier. So I think I'll end here, and I think we'll discuss after the next talk is over. If there are any questions, we can take it up later. Thank you.
Thank you so much, Dr. Badani, for such an insightful session. Yes, it is so very important to monitor the blood pressure. It's so very several timings, especially for the masked and this white coat syndrome, very newly introduced terminology. When I've been going through this term a few days back only, and the way you have described. So one question I have before I take up the questions from the audience. Sir, as we know, as per the diagnostic criteria of the hypertension, for example, if the diastolic is high, say around above 115, 120, around 115, and if the systolic remains at 135, so at what stage can we call it as? Can it be called as a stage 3 hypertensive or like some other
Okay.
stage?
So basically, you are asking about a patient who has a high diastolic pressure and a
Exactly.
near normal systolic pressure. That patient is labeled as a condition called as isolated diastolic hypertension.
Okay.
An isolated diastolic hypertension in people who are below 50 years of age needs to be treated very aggressively. Otherwise, it has a direct correlation to mortality, stroke, renal failure, and myocardial infarction. So what we would recommend very, very clear is that you should identify that even if somebody's diastolic pressure is more than 90, he will need drug therapy for hypertension management. So though the labeling part, when we say grade 1, grade 2, we probably do not really label them that way because diastolic pressure is very high. In that patient, you should rule out renal artery stenosis. You should rule out obstructive sleep apnea. You should rule out a person who is who is diabetic or a pre-diabetic with vascular disease. These are 3, 4 conditions that you need to rule out. But with a systolic pressure being below 135, diastolic above 90, medical treatment with drug therapy needs to be started. That's very important.
Okay, thank you so much, sir, for this clarification. We have a couple of the questions in the chat box. Participants are requested to please put your questions in the chat box and we will be taking up one by one. So one question is there from Raj Lakshmi. How about narrow blood pressure?
So basically, narrow blood pressure is not narrow, but it is called as narrow pulse pressure. Anybody who has a systolic pressure which is not very high, but a diastolic pressure is high, that person will fit into a narrow pulse pressure criteria. Now, these pulse pressures, we initially used to think that may have a very different prognostication. But as of today, we will look at systolic individually, diastolic individually. Young people, majority who are 25, 30 years, the diastolics are very high because of high peripheral vascular resistance and high renin-angiotensins and aldosterone system activation. So I think in narrow pulse pressure has got only this challenge of high diastolic pressures. Our focus should be on measuring both the values and deciding whether the person is hypertensive, either systolic or diastolic or combination of systolo-diastolic or combined hypertension. We say that. That's it.
So what could be the reason for this heightened activation of the RAS mechanism? It has been seen in many of our patients nowadays that everybody they're coming with the high renin-angiotensin activation and aldosterone
Yeah, so
activation?
the primary thing is your lifestyle, predominantly diet, high salt intake when we talk about, because again, salt and water retention is again going to increase purely when your renin-angiotensin is activated. Secondly, people, youngsters have got a significant high vasoconstricted status, so they have a very high peripheral vascular resistance. So main reason is your lifestyle, lack of sleep, many a times obstructive sleep apnea is also responsible for it. And your particularly your lifestyle, sedentary lifestyle, obesity, metabolic syndrome, all put together in a nutshell will bring you a proper case of uh, this lifestyle disorder, which probably activates your renin-angiotensin aldosterone system predominantly.
Okay. So
And
Shubhadra,
associated inflammation. So somebody has a high HSCRP,
yeah.
and along with that, the pressures are high. It's more of the vascular inflammation which stimulates the renin-angiotensin system predominantly.
Okay. Thank you, sir. So we have few more questions. Very quickly, we will take it up. Shubhadra ma'am has asked, is any age-specific guidelines or cutoffs? And is the measurement technique same for obese with high arm circumference and non-obese individuals?
Lovely question. So point is that the cutoff is from 18 years and above is what we need to, what I was discussing is above 18 years. For children, there is a Z value and there is a separate guideline. So in children below 18, do not use this criteria. And the second question is about your arm cuff. Definitely your arm size, it has to cover 2/3 of the circumference. So if you're an obese person, you need to have market, there's a larger cuff size available, which you need to use specifically for obese people. Otherwise, you will falsely show a lower pressure. A person who's hypertension may not be picked up very well. So you should use an appropriate cuff size for an appropriate individual. That's very important.
Okay. Which therapy is beneficial in treating hypertension if the patient doesn't need any medication or need to avoid it after some time?
See, I think one thing is very clear that hypertension, if it is above 140/90, any one of these two cutoffs, and you probably are starting antihypertensive therapy, let me tell you in practice, 97 or 96% of the people will continue antihypertensive therapy. You reduce weight, 1 kg weight loss will have a normally 1 millimeter BP reduction approximately. So if you lose 10 kg, you use 10 millimeter. But imagine you are on two drugs, you will go off one drug, but one will remain. But if you are on one drug, you really reduce your weight very well and your pressure comes down regularly, then there are chances that you may cut down on the pressure dosage or you may stop the therapy, but never do it on your own. And secondly, the weight loss regimens, as you all know, you are expert dietetics, sustenance of the weight loss is a major challenge. I may do it for the first 3 to 6 months, but I may not be able to sustain it for a long period of time. So there have been patients who have stopped the BP medications because of the BP going down and weight loss happening, but they had to again restart it purely because the weight gain has occurred and they are back to their hypertensive status previously.
Got it.
But
So,
most of them will continue therapy long term.
and one last question we will take up now. Are individuals usually with low blood pressure are at risk of high BP in future? Any association?
No, as such, nothing. Low blood pressure, predominantly what we see is in females, low hemoglobin, and they have a low systolic blood pressure. Mainly it's the hydration and the salt intake which is responsible for it. So, but it's not that low blood pressure patient today will become high blood pressure tomorrow. But low blood pressure patients have chances of giddiness, postural hypotension, blackout, syncope. To avoid that, have adequate hydration, adequate salt intake rather in those patients. And there are people who have postural hypotension, so elastic stocking usage in those people who are prone to develop giddiness on standing, particularly the elder ones, you need to be careful. But low BP causing high BP, there's no correlation about this. Yes.
Well, thank you so much, sir, for bringing such an insightful session amongst all of us, and especially commemorating the World Hypertension Day with such an elaborate and extensive lecture on, especially on the prevention part. Your specialization is also preventive cardiology. Well, indeed, it was an exciting and insightful session, and thank you so very much for your kind presence, for accepting our invitation, and for being here today. And imparting us with such great knowledge on hypertension.
Thank
Thank
you.
you, sir. Thank you
Thank you
so
very
much.
much.
I look
Thanks for having
forward
me.
to listen
Thank
to
you.
you more. Thank you.
Sure. Thanks.
Now, moving over to the next session, I would now request Aditi to please take over the session from here. Thank you.
So I'm happy to invite our next speaker, Dr. Eileen Canday. She has PhD in nutrition and is a registered dietitian. She's program officer of IAPEN India Nutrition in Transplant Core Group. She's secretary of IAPEN Mumbai Chapter. SPEN certified dietitian. She has done her pediatric onco. She's a pediatric onco nutritionist. She's also the RD board member. She has her IBS certification from Monash University. She is certified in body composition analyst. She's a nutrigenetic counselor and a certified diabetic educator. And most importantly, she is the head of the Department of Nutrition and Dietetics at Sir H.N. Reliance Foundation Hospital. Dr. Eileen, we are eagerly waiting to listening to you. So over to you, Dr. Eileen.
Thank you, Neha. Thank you for sharing that. I'll just try to share my slide if I'm allowed to. Okay. I hope you can see my slide.
Yes, just put it on full screen. Yeah, perfect.
Okay. So, yes, that was a wonderful talk. And I'm going to be talking about the hazards in dietary and nutritional management of pre-hypertension. I want to look at it from the perspective of a dietitian or a nutritionist. So I'll just try to okay, sorry. So we all understand that everything that you see is not true in terms of your nutrition. So there are a lot of hidden dietary hazards, and we know we have always related salt with hypertension. So this, what I am going to talk about, is the salt that you do not see and is the one that hurts the most. So it is the hidden sodium, maybe in your processed foods, packaged foods. You may be silently spiking your blood pressure, okay, with so many other aspects other than salt. It could be a caffeine-rich beverage or something else, which is actually a reason why it has even 1 mmHg change in your blood pressure. So the nutritional management we are looking at as food is just not fuel for the first line defense against hypertension. Of course, we are promoting a preventive nutrition here. We're talking about hypertension, and it's a warning. It's not a sentence. Okay, so it is just that your plate can rewrite your story. You empower the dietary changes. Uh, we doctor just spoke about what prehypertension is, so let me just dive directly into foods and the hidden foods. However, we know that hidden foods come from, and of course, hypertension comes from other factors, risk factors, lifestyles, genetics, unhealthy diet approaches, obesity, physical activity, stress, insulin resistance, sleep apnea, kidney disorders, and that list can go on. However, the importance of early nutritional intervention helps to reduce the risk by having a proper diet which can normalize the blood sugars if it is a secondary hypertension, that is, that's the cause of which your blood pressure is increasing. Non-pharmacological approaches, okay, long-term health benefits, and cost-effective prevention, and definitely nutritional intervention is one of the best. Now, hypertension, in fact, recently we read in the newspaper the global trend and the alarming trends that is with hypertension, which also doctor spoke about. And we know that we are at the edge. So there are many, many more hidden hazards. It's not only the salt shaker, which is the silent, sodium killer, but the soups, the sauces, the snacks. Okay, so here you need to understand the importance of label reading, hidden sugars, hidden, foods that are in packaged and processed foods, which highlights how these items can raise your blood sugar. So the hidden hazards, and what are they? So hidden hazards are, they are basically foods or certain microfoods that or nutrients that go unnoticed which will cause a harmful effect on your blood pressure. It could be sodium, sugars, unhealthy fats, and they are often found in foods that appeared healthy. Okay, or they may be one of your convenient food. Like, I often get a lot of patients who come, who are staying in hostels or who are doing night duties, or not necessarily that, they keep the so-called convenient foods at their home, thinking that it is harmless, right? And these packaged foods, if you actually look at what they contain, can you even imagine your pav bhaji made in your house and you have eaten it after 10 days? I don't think you can imagine that, right? Can you imagine you made watermelon juice, or for that matter pomegranate juice, and you have had after 6 months? Correct? You make cookies at home, and will your cookies last like forever? No, right? You add every food that you eat. You don't want to have the roti, sabzi, dal every day in the dinner, every day evening, or every day. The snack time will have something that is, chatpata. Even your imli chutney now you get is like, ready made, easy to have, squeezy types. So the condiments and the spices are also high in sodium. Not only high in sugar, but also high in sodium. So whether you go to a restaurant, take your takeouts, which are often oversized. Today, when you talk about portions, everything is like a super portion, because the cost of it is also super. So actually, instead of buying a single portion, you are buying like for 3 and 4 people. Although you may order one, but easily I'm sure 3 to 4 people can eat if you are not overeating. Whether it is your breads, there are some patients who come to me and tell me, I have jam and bread in the morning, uh, and I said, what about the salt? He said, no, 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 I have jam and bread in the morning. Jam is sweet and bread is not, it does not taste salty. And then when you actually educate them and you tell them how much of preservative, how much of sodium that goes into your baking powder, baking sodas, and in your other salt-based preservatives, that's when they realize that they're eating the entire day's sodium in that one food, not even one meal. So yes, sodium is the silent culprit. Now, besides the popular belief that sodium mainly comes from only the salt, approximately 70 to 80% of people in countries like ours and other countries take their sodium from other foods. So it could be processed meats, it could be breads, rolls, breakfast cereals, condiments, cheese, okay, and even foods that really, really don't taste salty. Your Chinese, what is so fondly eaten, and the Indian Chinese, what I mean is the Indian type of preparation for Chinese, which are like flooded with salt. So, of course, the monosodium glutamate is, the one that has an enhanced flavor and texture and gives you that feel of Chinese, without which it just sounds like a pulao rice, right? So, but that is sodium. Remember, we have to educate that to the patients or to our clients when they come to us, because they don't think, oh, really, it contains sodium. And but I don't use that. So that's something which needs to be told to the patients. Also, why are we talking so much about it as a silent culprit? So excessive sodium does affect your body. There is some kind of water retention, especially for the people who have problem in excreting adequate excess water. So people who have kidney diseases, people who have liver diseases, they already are having problem processing the amount of fluids that the volume of water that is entering their body. They're not, it's not in and out. So it's not like water in is equal to water out. So they have more water, which means their blood volumes are high. In fact, I get patients who come with edema or with ascites, and they tell me that, and they show me the reports, and I say, you have to stop, reduce your salt. So they say, no, no, doctor, you look at my report very nicely because it says hyponatremia. Remember one thing, these patients are so that their reports will show hyponatremia. They are showing lower sodium, but because of the edema and excessive water fluid in their body, the sodium gets very diluted, and therefore that is not their dry weight. So the sodium that you see in the report of the electrolytes is actually because of excessive water retention, and therefore the sodium shows low. So that doesn't mean that because the sodium is low, you give extra salt for that patient. When the sodium goes low, you have to restrict salt so that you have to allow the other drugs also to work. The patient may be put on drugs that will remove water from the body. Okay, now excessive of these kind of sodiums, which there could be a big mistake with because of which your blood vessels could be damaged. Okay, there could be a strain on the heart, there could be a risk even of organ failure. So therefore, in a long term, high blood pressure can lead to not only your kidney but also your heart failure. So when a patient comes to me with CCF, congestive cardiac failure, with liver, with kidney, that's the first thing I am going to see is how much of water he's retaining, how much of sodium is allowed for him, and we have to restrict both these things. So these things have to be looked at very carefully because this is fatal and it is life threatening. So yes, when we talk about reading the labels, it's important for these patients. I agree that it is important also for normal people to look at labels, because these days it is not only the people who have these big diseases, heart, kidney, liver, who have to look at sodium, but it is even the common men, common people, common children that are having hypertension. Okay, so the nutrition facts that you look at in the label are, it should be having certain amount of content to be read right. So when you say low sodium, when you say moderate, when you say high sodium content, it has to have a number. Yeah, most of the non-Indian food labeling products do have the daily value, okay, based on 2300 mg for an individual, especially with hypertension. Frankly, it is not taken so seriously because one is that people themselves don't know what should be their daily value. Secondly is they don't know how to interpret that, and you as a dietitian or a nutritionist should be able to tell them how to interpret these kind of labels. So explain to your patients how to look at hidden terms, like a product which will have sodium benzoate. Anything with sodium means it has got salt. Okay, and we think that patients understand this. We think that yes, people know that sodium is salt, but sodium is salt, you know it because you have studied it, but a common man does not know that. You have to explain to him that when you read the word sodium benzoate or disodium phosphate, baking soda, yeah, baking soda, there's no way sodium nor there is salt is written in it. So baking soda, the term itself does not implicate salt anywhere. Sodium nitrite, all these are foods that will have an effect on your blood pressure. Now, why am I talking about refined carbohydrates? See, actually, all these things go hand in hand. Whether you're talking about your health, you're talking about your weight, as the doctor just said, each time you reduce 1 kg, your blood pressure drops by 1. And therefore, we need to understand that when we also talk about ultra processed foods, what are we talking about? We're talking about this combination. We're talking about the sugar salt combination. We're talking about foods that are high in both in sugar as well as salt, which will cause insulin, spikes, insulin resistance. There is an activity, a sympathetic nervous system activity is affected. Also, there is elevation of triglyceride inflammation. It's really sometimes very interesting to understand when I tell the patient, oh, your triglycerides are high, you have to reduce, you have to stop your sugar. So they said, doctor, my triglycerides have increased, why do I have to stop sugar? And then I have to explain to them that triglycerides do not only increase with having fatty foods, but they also increase with having refined carbohydrate foods. So these are the some of the things which are hidden from us. Okay, so imagine a lay person how hidden it is with them. Coming to hidden uh, salts, we also have hidden sugars. Since my topic is not really hidden sugars, but I said this is like a jodi, it's a pair. You have salt and sugar as a pair. I always tell my patient. So they, by the end of the session, they said, "Doctor, I'm confused now. I've got so much of information. I don't know what to do." And I just give them an acronym, and I said SOS. And they said, what is SOS, doctor? I said, reduce SOS, salt, oil, and sugar. You'll be fine. That's the end. That's the summary of my entire conversation with you. And then they understand, oh yeah, salt, oil, and sugar is SOS. So that was easy to remember. Okay. So when we talk about hidden sugars, we talk about high fructose maltodextrins, corn syrup, cane sugar. The best thing is people think date syrup, the best superfood that they have found, which nobody else had it. They are the only ones who found it. And then I have to tell them, no, no, no date sugar as well, because everything. And then if really they insist, then I tell them how to have it, how much to have, when to have. All those things do come up in a conversation. So misleading health claims, what labels does not tell you is low fat means what. So now FSSAI may have said, oh, you can write low fat on your label because your product does not have high fat foods, but it will not tell you everything. Often these low fat things will have high sugar to make up for the loss of flavor, because somewhere they have to get flavor taste. Okay, gluten free, they'll tell you it is gluten free, but they will not tell you that the non gluten atta that they have used, they have removed all the fiber from it and made it very refined. Okay, so when they tell you no added sugar, it also, this is the most misused claim actually. No added sugar. Okay, so people wonder whether honey is sugar, whether added fruit concentrate is sugar, whether fructose is sugar, or only sucralose is sugar, or only sucrose is sugar. So all these things happen. Cholesterol free, it may not be trans fat free, made with real fruit. Yes, of course, your pomegranate, your oranges will be made with real fruit, but in that bargain you have added a lot of things. As I told you in the beginning of the lecture, when you make a fruit juice at home, you will not even keep it out for 4 hours because you'll be worried, oh, kharab ho jayega. But how is it that by mistake, it often happens in my house, or with the people I deal with. So after having the real, or the natural, or the most what to call it, preservative free fruit juice, and they have had half of it and they've left it on the table, and eventually it's not refrigerated. So when I get up in the morning, I should have it spoiled, right? No, it's not spoiled. It's as good as new. So it means that there is something that is added to these, okay, which is preserving these fruit juices, which is preserving your cookies. You make homemade puddings, and this thing, it will not stay, but you have it from the store bought and it will stay like magic, right? So these are some of the things I think we as dietitians should be able to perceive and understand, and ask ourselves questions that, when we talk about convenience foods, and when we explain what convenience foods is to our patients, we have to also be able to give them ideas for homemade convenience foods. Okay, convenience foods are not to abuse your health, but it is to improve the way you are living your daily life. Okay, coming to the misconceptions of consumers, that healthy claims low fat, yogurt is the most asked question for. Can I have Greek yogurt? Can I have this yogurt? So, they do believe, because they don't know that whether gluten free is better for them or no, they just stop gluten because that's the trend. And then they feel good about it, but they don't know that they have actually stopped the biscuits, and they've stopped the bread, and they've stopped the other things that are gluten free, which are actually, I said, the SOS combination, right? So by removing gluten, they have actually taken care of the SOS. And that's what making them lose weight. That's what getting their blood pressure down. So if it helps them, I ask them to continue. I said, okay, good, it's doing you good. Please continue. And I also explained to them that what's the difference. See, we have to tell them the right thing, that why it should be gluten free and why you need or you don't need a gluten free diet. However, if it is helping you, please continue with your gluten free diet. Okay, so there are a lot of other talks about natural, organic, all these things do come up, but I'll just want to stick to hypertension today. And I would tell you that the health halo effect has to be looked at. Packaging design, fortification, look at how the food is being fortified. Okay, so there is a role of diet in blood pressure regulation, sodium, potassium, magnesium. These are the key nutrients. Calcium, fiber, antioxidants, they also have a key impact on your blood pressure. The DASH diet, the famous dietary approaches to stop hypertension. ये question तो आता ही है exam में. So, but do we know what it is? It is a very simple, easy to eat diet. Basically, it's घर का खाना. And we have to, if we explain to the patient, it would be really great. Some of the functional foods, I will go through it very, very quickly. We know about it, but it's the allicin in garlic, the rich omega-3 fatty acids, ALA in flax seeds, the antioxidants, anthocyanins in berries, catechins in your green tea, your vitamin C, and the other goodness of fiber in your citrus fruit. Leafy vegetables. People love taking magnesium these days. Have one bowl of one of these green leafy vegetables every day. It works like magic. It really works like magic. Nuts and seeds, the selenium, the zinc, the good fats that you get from them, okay, can be included. Include lots and lots of legumes in various forms. Nowadays, the kind of recipes that are available is amazing of legumes. Literally, you can make everything out of legumes, even mock meats. So you can use your legumes for making idlis, dosas, chilas, whatever, but don't make mock meats because mock meats are very high in sodium. They are very high in preservatives. They are very high in other things which you may not like. So even if you tend to be a vegan, or if you're giving a vegan diet, be careful of the mock meats that are available. You rather have a meat unless it's for religious reasons. So mind the mock meats, especially from these. The berries, we've heard a lot about berries. The omega-3s from, or the olive, the goodness of olive oil. You can use our Indian oils as well, rice bran and mustard and meats, whatever traditionally you all are using, whether it's, even if it is a coconut oil. Carrots, tomatoes, lycopene from it, yogurt, which is a natural probiotic, herbs and spices. Our kitchen is full of these. Encourage this to be added to our foods. Eggs, omega-3 from fish oils. Okay, so basically lot of strategies, lot of strategies. I can't go through every, but I can just summarize it as saying that the dash of discipline keeps the pressure down. Okay, the effectiveness of DASH diets, fiber, potassium hydration is the nature's trio, and to tame the pressure, encourage a plant-based balanced nutrition. Remember the vegan diet, but no mock meats. And before pills comes the plan. So approach that kind of an approach. Read your labels, rethink health claims, and replace your hidden hazards with the whole fresh fruits. I would just say small dietary changes can have a big impact. Hidden ingredients matter. Read labels, choose fresh, make mindful choices, and make your decision to prevent and to lower your blood pressure. Thank you so much, and I would be happy to take questions.
Thank you so much, Dr. Eileen, for the insightful talk. As always, it's been wonderful listening to you. You bring so much to the platform, and it's always very, very interesting listening to you. So, Dr. Eileen, before I take up the questions, there are a lot of requests for repeating of the content. The uh, the recordings would be shared on NSI Mumbai Chapter YouTube. I'm not sure if it will be shared on IAPEN Chapter also. So once the recordings are uploaded, whoever wants to,
Yeah,
go
you
back to
can
the
share it with
videos,
me. I will
they
share it
can,
to the
yeah.
admin
So
groups. Yeah.
they can go back to the slides at that point of time. So that's one thing I wanted to tell to people. Also, I request everyone to stay till the end, because you need to fill the feedback form for getting the certificates. So, Dr. Eileen, there is one question that that is there, that what is your approach on artificial sweeteners, and for especially for somebody who's suffering for hypertension, or and specifically they're asking, is consumption having a lot of side effects? Long-term consumption would have side effects.
So first of all, you have to understand why you are giving an artificial sweetener. Okay. So the word artificial itself puts me off. right? So I don't like anything that's artificial. Now, coming to the science of it, it's not that artificial sweeteners are a banned thing. Okay, it can be had in the amounts.
Just I'll add on. So they specifically mentioned sugar, alcohol, so sucralose, erythritol, xylitol, monk fruit. So not specifically per se artificial sweeteners. They're talking about, these forms of sugars.
Yeah. So sugar is sugar, right? Any type of sugar you have, whether it's artificial, whether it is alcohol sugars or any sugar is sugar, it will have the same effect. So if somebody is supposed to, not consume sugar, they're not supposed to consume any type of sugar.
Right.
Only when it is required, I would prescribe it, because there are now artificial sweetener itself is a big topic for another day. But I would just say that consider it as sugar.
Considered as sugar. Great. So we have one question from Aisha Shah. She wants to know, is there a difference in recommended intake of sodium for normotensive, pre-hypertensive, and hypertensive? So is there a difference specifically between pre-hypertensive and hypertensives? Is the recommendations different for sodium intake?
Okay, so we don't really go by that, what to call it, categories. We go by what is the disease condition of the patient. We give sodium recommendations not based on the level of blood pressure you have, but on the kind of disease that you have. Now,
Right.
if you're pre-hypertensive and if it is like a primary hypertension, that's when you do a restriction. However, if it's a secondary hypertension, we are very particular of removing all sources of salt, which is the cause of the secondary hypertension. Obesity, this, that, and everything else. So, first of all, go by the normal sodium intake of not more than, 1 teaspoon per day for a normal person. The person is hypertension and you know that in future, or your family history has it, or you know that you have had another issue with your heart, your kidney, or liver, that's when you have to restrict the salt. So for liver we restrict up to 2 grams, for heart also we restrict up to 2 to 3 grams, for kidney also we try to restrict based on what is the reports of the patient. So it is based on the person. Nevertheless, overall, even if you're pre-hypertensive or hypertensive, we ask you to reduce your salt intake from all sources.
So I'll ask you one question, which is not there, but I'm sure everybody would want to know that. How do you train your clients as to how to measure salt intake? Do you tell them to use salt sachets, or do you tell them to weigh the salt every day and keep it at the start of the day and then use it? So what is your counseling tips as to how do you control your salt intake?
Okay, very, very right. The most apt question, I would say, because that is something which is practical. So when it all depends upon who the patient is. So there are some patients who come to me and they say, "Oh, I'm very happy taking 1 gram sachet from Amazon, and I will use my 2 grams per day or 4 grams per day. I know how much of sachet to use. 1 gram
Hello?
sodium chloride." Hello? Yeah, 1 gram sodium chloride. So that's how they use it. There are some patients who don't know how to measure it. So then I also tell them to use a measure spoon, and on their measure spoon they can account for 1 gram and keep it at keep it aside and use that in the entire day. There are some people who says I cannot do all these things, and I want to have a low sodium diet, but I don't want to measure. So those are the people whom we do a calculation when we are giving them a diet and see how much of sodium is coming from their diet. Okay. And according to that, we tell them how to do the addition. There are people who don't require strict sodium restriction. So for them, we just tell them no extra salt on the table or in your salads. Just have normal low sodium food from the kitchen.
I'm sorry I lost in between, but I'm sure your the answers question is answered. Another question that is there is, so it's a very practical question actually. Just a second, Dr. Eileen. For kids, okay, this is specifically, I think, dietitian wanting to know how do you counsel. So, this whole thing about processed versus ultra processed. So this question is, for kids to give them variety at home, is it okay to give them pasta, noodles, etc. From the packets? Or are these also considered under processed food? So I think this is the difference between processed and ultra processed that I think you'll have to describe a little bit.
Yeah. So when we talk about grains, the grains can be from various sources, whether it is processed as an atta in your chakki, or whether it is processed as a pasta or a noodle in another this thing. So whether you process your wheat to a pasta or you process your wheat to a semolina, it means the same, right? The sodium that is added is how much salt or sauces you add to it, rather than looking at how your wheat is processed.
Right. So I think that answers Meghna's question. So though you've answered this question, I'll still take this question because you did answer in terms of date sugar. So similarly, there's a question in terms of jaggery. Can we take jaggery? You already answered it for date sugar, but I think you should just answer for jaggery also because Dr. Eileen, you wouldn't believe, like I have seen nutritionists, I have seen doctors, I have seen so many people doing marketing of products which say no sweet sugar, but has contains dates or
You
sorry
know,
contains jaggery.
I'll tell
And
you
when
one
I
thing.
see those ads, I am like, how can you say that it does not have sugar? So I think that's one thing you should
Yeah, I
address.
think this question is not a question because it has
Yeah,
to really be thrown in the dustbin. It's the first lecture, first class we learn in FYBSc. So that means somebody who has not studied chemistry, studied biochemistry, and does not understand the structure of sugars should not be doing nutrition.
exactly.
So,
Exactly.
literally don't even ask me this question.
So very recently, I saw Instagram reel by a very senior person, either a doctor or nutritionist. She very clearly said sugar is made from cane, which is from which jaggery is made. It's just a refined format. So I think, as Dr. Eileen said, that please don't promote jaggery as an alternate to sugar. It is sugar at the end of the day. Uh, Somebody's asking that you talk about hyponatremia, where we have to restrict salt and not give excess. Can you give an further explanation to that?
Okay. So, hyponatremia, there's a cause of my hyponatremia, and the cause is excessive fluid retention. Okay. The fluid retention may be two reasons. One is excessive intake. The second is bad excretion. Okay. So in patients who are on dialysis, they have certain ways in which they remove the water or the fluid from their body. They retain water sometimes even after dialysis. Similarly, if a person with a liver disease has got ascites and has got fluid retention in their abdomen, after tapping also there is a lot of fluid that still stays. You take two glasses in one glass and two glasses, one with water, one without water. You add 1 teaspoon of salt in each one. Obviously the one which has got water, will the salt will be more diluted than the one
Right.
which without water. So the dry weight of the body will have the right sodium, but a body weight which has got fluid inside it will be diluted. You will not feel it as salty as the one that is got with dry weight. Hence here in this case, dry weight sodium is very, very important, and therefore consider that the person has got fluid retention and therefore has got hyponatremia.
Right. Thank you so much, Dr. Eileen. We'll take one last question, which again comes back to the salt, sodium, and water balance. Does drinking excess water being harmful? So is excess water intake harmful?
So anything in excess is harmful, right? So your body does need certain amount of water even in measurement. So when I tell a patient or a normal individual how much of water to calculate, I just say multiply your weight by say around 30 to 40 ml per kg. So if
Okay.
you're doing excessive exercise or you're sweating a little too much, take the higher side. So I just tell them take your current weight and multiply into 40. If they're not doing that in the AC all the time, then multiply your weight into 25 or 30. And that's the amount of water you need. Anything beyond that will be like excessive work for your entire body. You're flushing out your nutrients, you're flushing out your micronutrients, your fats, your water soluble vitamins, sodium excess, etc. So there is no need of having anything excess. You need to have adequate.
And yeah, thank you so much. I'll take one last question because this is from Subhadra ma'am. Can high salt or sodium intake without hypertension lead to CDDs? Many individuals consume high sodium on a daily basis.
Yes, definitely. So again, you're damaging, right? You're damaging your blood vessels. You're damaging your this thing, because high sodium on a daily basis is just not recommended. Even sodium you need to have in a recommended allowance. There are people who are having 10 to 15 grams of salt per day without even knowing that they're consuming that much salt. So definitely we have to not encourage people to have high sodium foods on a daily basis.
Thank you so much, Dr. Eileen. It's always a pleasure listening to you because you bring so much practical experience and knowledge, and you share it with all the participants always without holding back. So thank you so much, Dr. Eileen, for joining us for the webinar today and sharing your knowledge on pre-hypertension and salt and sodium, and specifically giving those practical tips about, how to guide your patients, whether it was SOS, whether it was reading about, different sodium salts on the label. I'm sure, or the different functional foods that you talked about. And so I'm sure everybody learned a lot today. If there are any other questions that we've not been able to answer, we'll request Dr. Eileen to answer them, and we'll share them on chat here. Because of shortage of time, we cannot take more questions. The feedback form link has been shared on the comments. So I'll request everybody to please fill the feedback form. Over to you, Aditi.
Thank you so much, all of you.
As we come to the close of this impactful session, on behalf of LSI, NSI Mumbai Chapter, and IAPEN Hypertension Core Group, I take the privilege of proposing the vote of thanks. We extend a heartfelt gratitude to our distinguished speaker, Dr. Rajesh Badani and Dr. Eileen Canday, for sparing their valuable time and sharing their expertise with all of us. A special thanks to Dr. Neha ma'am, Professor Bijoya ma'am, and all the organizing team members of NSI, IAPEN Hypertension Core Group, and LSI for making this webinar a success. Last but not the least, deep thanks to all the participants for your active involvement. Let's continue spreading awareness and working together towards a healthier future. Have a great day ahead.